coordinator. Welcome to the second of our series training on hypertension education. Part 2 today will continue on recognizing disparities and associated risk factors related to hypertension. Our presenter for this series is Alex Bernadette, fourth-year medical student at Tulane University School of Medicine. As we will attempt to stay on time during the webinar, we will again hold all questions until the last 15 minutes. All participants will be in listen-only mode. Please type your question throughout the broadcast in the question box located on the webinar screen. If we run out of time, you can email your question and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in this series. Alex, you can begin.
Okay, thank you, Shannon. And thank you everyone for attending today. As Shannon mentioned, this is part 2 of a 3-part series of webinars discussing hypertension. And today we want to discuss hypertension and health disparities and what you can do in your clinics to help address the issues involving hypertension and their disparities. As Ms. Shannon mentioned, we'd love to encourage questions and have questions from the audience. Please feel free to type them in at any point and we'll address them at the end of the presentation. So let's get started. Okay, so we want to spend a couple minutes from the get-go reviewing a little bit of what we talked about during the first part of the webinar for those of you that weren't here, or as just a quick refresher. So as you can see, hypertension or high blood pressure is an extremely common medical condition in the United States, and especially for Louisiana. The map that you see below kind of highlights the areas where hypertension is most prominent, Louisiana being the 4th highest rate of hypertension in the country, with 39, almost 40% of adults reporting hypertension in the past year. The only states higher than Louisiana would be West Virginia, Alabama, and Mississippi. So clearly it's a very prevalent problem on a national scale, but especially in Louisiana. And breaking down further into just the state itself, this map is from the Center for Disease Control and looks at the hypertension rates in different parishes. The redder the marking, the higher the rate of hypertension, but as you can see, most of the state is some shade of red. So clearly a very prevalent and common problem for us here in Louisiana. And this chart is from the American Heart Association, and you saw it in the last part of the webinar, and just kind of reviews different blood pressures and what we consider hypertension to be. So as you can see from this graphic, high blood pressure is considered any blood pressure that's greater than 140 systolic, which is the upper number in a blood pressure reading, over 90 diastolic, or the bottom number in a blood pressure reading. Some of you may have heard or be aware of excuse me, the new blood pressure guidelines that have been released in August of 2014 called the JNC8 guidelines. And these kind of raise the level of what we consider hypertension in some patients. But for the purposes of this presentation and the statistics that you're going to see, we consider anything, any blood pressure above 140 over 90 to be a hypertensive patient. Okay. And lastly, to review some of the risk factors that were discussed in last presentation and potential causes and patients that you'll see presenting with hypertension. One of the most prominent risk factors is a person's age. Usually the older that people get, the higher their risk of hypertension will be. Race is another risk factor for hypertension. We tend to see hypertension more in African Americans when compared to whites. And also black patients tend to suffer more complications from hypertension, such as stroke, heart attack, kidney failure, significant illnesses that cause disability and loss of function. Family history, so patients that have parents or sibling with hypertension have a higher risk of having hypertension themselves. Obesity or being overweight. As you can see, the larger somebody is, they tend to have higher blood pressure. Physical inactivity. The less you are active and working, the higher your blood pressure can be, as you can read in the slide. Okay. Other risk factors, tobacco, which not only damages the blood vessels in our bodies, which can lead to hypertension, but also causes an immediate spike in blood pressure with use. So, and also secondhand smoking can increase hypertension for those that are exposed as well. Too much salt, or otherwise known as sodium in the diet, tends to retain fluid in our bodies, which can raise blood pressure. And also too little potassium in the diet, another element, helps, and potassium helps balance the level of sodium in our bodies. So with low levels of potassium, we tend to have different imbalances in our salt. Okay, and lastly, for risk factors, drinking too much alcohol can cause blood pressure issues. And we'll discuss this a little bit later on, but you can read that there. Stress, so stress can lead to higher blood pressure, especially chronic stress. People that are chronically stressed tend to have higher blood pressures on average. And others, medical conditions or comorbidities can cause hypertension, or at least increase the amount of hypertension that patients may experience. So kidney disease, diabetes is a particularly common chronic condition associated with hypertension. And sleep apnea is another common illness. Okay. So to jump into our presentation after that brief review of what we looked at, we want to discuss kind of 3 different questions for this section of the webinar. First, we're going to address what population is most affected by hypertension by looking at different statistics and briefly going over the patients that we see in Louisiana's federally qualified health centers. And then looking at what causes the differences in, or disparity in the patients that are affected by hypertension. And then finally, at the end of the presentation, we'll address ways that you as a healthcare provider can help address these issues that we bring up during the presentation. So the population affected by hypertension, almost 1/3 of Americans have a high blood pressure, or a blood pressure greater than 140/90. And as we mentioned, in Louisiana, that rate is much higher, getting close to 40% by the CDC's statistics. And the Healthy People 2020 was an initiative that was started by the Federal Office for Disease Prevention and Health Initiatives, and they set a large range of different health goals for that healthcare is aiming to obtain by the year 2020. One of those goals was to reduce the national rate of hypertension to 26.9%. So it's definitely, hypertension is an issue that is being addressed at a national scale and needs to especially be addressed in Louisiana, given its prevalence. And certain populations tend to be at higher risk for hypertension, and this can be determined by the risk factors that we discussed, genetic or biological predisposition to getting hypertension, and social determinants of health, which we'll discuss later on in the presentation. So this slide looks at the hypertension rates in Louisiana's federally qualified health centers, or FQHCs. And this data was taken from the Uniform Data System, or the UDS, which is a publicly accessible domain, and we'll provide information for how to access that at the end of the presentation. And these rates look at adult patients that were at FQHCs between the ages of 18 and 85, and looking at their diagnosis of hypertension. So you might notice that the percentages in this study are a little bit lower than the ones that we were discussing earlier in the CDC studies. But what's important to recognize is that Louisiana, compared to national statistics, is still significantly higher. 4 percentage points, almost 5 percentage points in some cases. So in the FQHCs itself, of the over 222,000 patients that were served at Louisiana FQHCs, over 65,000 of these adults had hypertension, making hypertension the most common primary diagnosis for patients that were coming to FQHCs. And of all the office visits in 2014, the most visits of any primary diagnosis were for hypertensive patients. So clearly it's a very prevalent issue and very common in the patients that you are seeing at your clinics. So looking back at other risk factors that may cause a difference in hypertension, this data is from a national study that was conducted and mainly just points out and reflects two different risk factors. Looking at age, as you can see, the older that patients get, the higher that their risk of hypertension goes. And one particular important point to note here is that for older women, specifically women above the age of 65, they'll actually tend to have higher rates of hypertension than men of the same age. And specifically looking at the 75 years and older, nearly 80% of women above 75 years old can have a diagnosis of hypertension. So not only is an increase in age an important risk factor for hypertension, but also older women tend to have a higher risk of hypertension. So something to remember there when you're dealing with patients in clinic. And looking specifically again at national data for differences in hypertension and race throughout the United States. As you can see, African American patients of both genders have more than a 10% higher rate of hypertension when compared to the second highest race group, which is the white patients. And so clearly this issue is affecting African Americans at a much more significant rate than other ethnicities or race groups. And these are the top three race groups from this national study that was conducted. So to look specifically at the Louisiana data for hypertension, this data set looks at patients who were diagnosed with hypertension and on medications and visiting their FQHCs and actually had their blood pressure controlled with medications and with lifestyle changes and frequent doctor visits. So almost 62% of Louisiana's hypertensive patients were controlled. But looking at the race of the controlled patients, you can see here that the primary majority of patients that we're seeing with hypertension in the FQHCs are African American, followed by white patients, and then Hispanic Latino patients and other patients, which other patients can include Asian, Native American, Pacific Islander, and other ethnicities. So clearly we're seeing that African Americans have a higher rate of hypertension. We're seeing more African Americans in clinic with high rates of hypertension. And that tends to be the patient population that we're addressing in clinic. And also to highlight that, looking at the statistics for the FQHCs and the percent of patients that come to FQHCs, we're seeing almost in last year, almost 60% of the patients that we see in FQHCs are African American. There's a significantly increased Hispanic and Latino population as well. So kind of interesting statistics here to see the demographics and how they're changing over the last 4 years or so. So we're seeing that African Americans have a higher rate of hypertension at baseline. They're coming in to see us in clinic more often, and we also in general, see almost 60% of our patients are African American patients. So we just talked about a little bit about the population most affected by hypertension. Let's take a look at different reasons that are causing this disparity or this difference. So to really quickly go over what a disparity implies or is defined by, it's a particular type of health difference that is closely linked with social, economic, or environmental disadvantages. So these disparities can affect groups of people who have experienced obstacles in health based on a number of factors. So a disparity can be anything that it makes impedes the delivery of health care to a certain person for a number of different reasons that you see on this slide. So to look specifically at hypertension in African Americans and this disparity, hypertension prevalence among African Americans in the United States is actually among the highest in the world for a specific population or group. So compared to any other country or ethnicity or race, African Americans in the United States have the highest prevalence of hypertension. And so when compared to other races, African Americans also face more premature onset of hypertension or an earlier onset of hypertension. They're more likely to suffer target organ damage. So this is hypertension increases your risk of having heart damage, kidney damage, strokes, decreased function and mobility. And also African Americans tend to present with a higher average blood pressure initially than other patients in the clinic. And as you can see from this graph, which was taken from the American Heart Association, African Americans experience a significantly increased death rate due to hypertension specifically when compared to other races. All right, so this graph is looking at differences in race and ethnicity in terms of awareness, treatment, and control of hypertension. So each of the clusters represented here on the graph is a different race. So on the left is actually the total population in the yellow. In the red is the white population. Kind of the gray is the black population here, and on the right in the blue is Mexican American and Latino population. So just looking at this chart, we'll see that in terms of awareness of hypertension and patients knowing about hypertension or knowing that they have hypertension, we actually see that African American patients tend to perform better than the general population. When it comes to treatment of hypertension and being treated with medication, the numbers kind of even out a little bit more. And then when it comes to actual control of hypertension, we'll see that the African American population takes a significant decrease and actually falls below the total population in that category. And so even though we see that African American patients are aware that they have hypertension, they're getting treated, they're not really having the same amount of control that you would expect. So we might wonder why that is. And there are many different explanations that exist. Some commonly cited reasons that we'll discuss here include the risk factor exposures, physiologic or kind of biological determinants, genetic predisposition, and social determinants of health. So to start, we'll look at the risk factor exposures. To review, the common risk factors for hypertension include age, race, family history, obesity, lack of physical activity, tobacco and alcohol use, diet, stress, and chronic medical conditions. And we see that many of these risk factors are prevalent in the patients that we serve in Louisiana's FQHCs. The Institute of Medicine actually did a study that pointed out the 5 most significant risk factors of hypertension. So something to keep in mind when you're looking at patients with hypertension: obesity, an unhealthy diet, lack of physical activity, and a high sodium intake or low potassium intake. So a lot of these risk factors specifically deal with diet, weight, and physical activity. So looking at physiological determinants specifically, there are some things that are higher prevalence in African American patients when compared to other patients, or certain things that might be higher in white patients or Latino patients. But looking specifically at African American patients and reasons that might cause a higher rate of hypertension, African Americans tend to have a higher salt sensitivity. So for when taking in sodium or salt, this tends to affect African American patients more and affect their blood pressure more than does other races and ethnicities. Lower levels of plasma renin, which is a chemical in the body that controls blood pressure through a system of reactions. And also, renin happens to be a target for certain medications that we prescribe for hypertension, including ACE inhibitors and ARBs. And so African Americans have lower levels of this control of hypertension, and also those lower levels prevent certain medications from working as well in African American patients. And the actual blood vessels and the vascular function themselves, there tends to be more of a sympathetic or vasoconstrictive activity in African American patients, which can increase the rate of blood pressure. And also, when compared to other races, African American patients tend to have a lower level of nocturnal or nighttime fall in blood pressure. So if somebody is a hypertensive patient, blood pressures tend to be lower at night, but in African American patients, we see that they tend to keep this high level of blood pressure at all times, which can lead to significant issues in the long run. So looking at the genetic predisposition, and this is the thought that maybe certain races are prone to one disease more just based on their genetic makeup. However, this was a study from the Journal of the American Journal of Public Health in 1997, and they actually looked at different black patients in different settings and their rates of hypertension. So you can see that this study actually showed that the prevalence of hypertension in black patients in Africa and the Caribbean were much, much lower when compared to black patients in the United States. And the actual rates of hypertension in Africa and the Caribbean looked more similar to the white population in America's rate of hypertension. So this finding suggests that rates of hypertension for black patients in the United States are more likely due to social factors or environmental factors than an actual underlying biological vulnerability. Okay. So what are these social factors and environmental factors that might be making a difference? Brings us to the social determinants of health. So as a quick definition, the social determinants of health includes any conditions in which people are born, grow up, work, live, and age in. There's a wider set of forces and systems shaping the conditions, and this includes economic policies and systems, development agendas, social norms, social policies, and political systems. So the social determinants of health really look at things that affect a patient's health and a patient's health outcomes that are not directly linked to treatment or a health provider's plan. So the Healthy People 2020 initiative defined the 5 key areas of social determinants, as you can see with the graph, and also listed: economic stability, so financial stability, education level, social and community context, health and health care, and the neighborhood and built environment or social environment that patients were around. Okay. And specifically for hypertension, there's beginning to be more and more recognition in the healthcare community that there are more, hypertension has a more direct link to social determinants of health. So this was an article from August 3rd of this year, and the American Heart Association was acknowledging that social factors play a larger role. So Dr. Clyde Yancey, who was the author of this report, cited that it's a very complicated space and there may be a number of variables beyond people's control that have an impact on their health. And the statement looks at social and economic status, race, ethnicity, social support, culture and language, access to care, and place of residence as being significant determining factors of health. And although in the past the American Heart Association traditionally viewed cardiovascular disease as modifiable and non-modifiable risk factors, they are acknowledging that they have to consider the social factors as another piece of the puzzle. Okay. So the top 10 social determinants of health, this was a study conducted by the World Health Organization, looking at the top 10 determinants. And the graph on the right that you see is from a University of Wisconsin Population Health Institute study. And they spend a lot of time looking at the social determinants of health. But to cover the World Health Organization, and these are in no particular order in terms of number 1 to 10, but these are just the top 10 that they cited. So a low level of social status, this includes people further down the social ladder, and people with a lower social status tend to have twice the risk of a serious illness and premature death compared to people with a higher social standing. And relentless stress levels, which as we cited was a risk factor for hypertension, but anxiety, insecurity, low self-esteem, social isolation, and lack of control over home life have powerful effects on health. And adversity in early life includes poor emotional support and slow growth can actually raise the level of lifetime risk in patients. Social exclusion, this includes unemployed patients, ethnic minority groups that don't have a good support system, guest workers, disabled people, refugees, and the homeless population are at a particularly high risk. We actually see that the homeless population has the highest rate of premature death. And stress at work, so there's very significant evidence that shows that stress at work plays an important role in contributing to the large social status differences in health, sickness absence, and premature death. And unemployment, so there's studies that show an increased risk of premature death in unemployed people and their families. The absence of social support, a positive social support environment actually has a protective effect on health, and without this support environment, patients tend to suffer poor health outcomes. Addiction obviously can be a strain on social and physical health, and smoking is actually a major drain on patients' incomes and a huge cause of ill health, premature death, and as we discussed, hypertension. And poor nutrition, this includes a lack of food, but also, as is the case with a lot of American citizens, an excess food intake. This contributes significantly to obesity, cardiovascular disease, diabetes, and as a result of that, hypertension. And a physical environment that doesn't promote physical activity. So when patients aren't able to walk, bike, take public transportation, or otherwise exercise, they tend to suffer poorer health outcomes. And it's important to notice in the graph, or the figure on the right, that the actual clinical care of medicine, according to the Wisconsin study, only accounts for about 20% of overall health outcomes, and that healthy behaviors, social and economic factors, and physical environment actually make up 80% of how well our patients do. So it's important that we consider these social determinants of health, and why we wanted to spend a significant amount of time discussing them. It's because they have almost an 80% impact on a patient's health outcome. So looking at Louisiana specifically, there's actually a really great website that I encourage everyone to write down or look up after this presentation, called the County Health Rankings and Roadmaps, which is a project by the Robert Wood Johnson Foundation that looks at, it breaks down into, in Louisiana's case, parishes, breaks it down to a parish level of specific health factors that influence patients in those different parishes. So the darker blue in this graph is the patients face more adverse health factors, and then in the lighter blue, patients have better, whether it's physical environment, higher education, lower levels of the social determinants of health. But I encourage everyone to, after this presentation, to explore this website, and you can look at specifically within your region how you compare with the rest of Louisiana and where you stand when it comes to the social determinants of health. Okay, so we talked about what causes the disparity in hypertension and the social determinants of health and other risk factors, and now we want to spend some time briefly on what you can do specifically to address these issues. So there are many issues for patients that make it difficult to achieve blood pressure goals and limit their hypertension. We discussed the social determinants of health, false health beliefs. So for patients with hypertension, it's difficult for some patients to be convinced that they have something going on. Patients don't normally feel sick or don't know when they have hypertension, so it's difficult for them to recognize that there's an issue that needs to be addressed since they're not feeling any effects directly. It's difficult to change one's lifestyle when it comes to exercise, dietary habits. This is a big barrier for addressing a lot of illnesses, but hypertension in particular. And also unrealistic expectations with hypertension treatment. So it's important to emphasize to patients that hypertension isn't like a cold or a broken bone that heals and is fixed. Hypertension is something that's at a basic level and a chronic condition that needs to be dealt with. Medication side effects especially create issues for patients to follow their treatment with hypertension, which then leads to poor medical adherence if patients are experiencing side effects that either they weren't aware of or didn't anticipate being as significant as they turned out to be. And also, patients have poor knowledge about hypertension and its consequences. So talking about the patients with hypertension having higher risks of heart attacks and strokes and kidney damage, a bunch of other really significant health outcomes that will limit their function and disability later in life. So to break these down really quickly and addressing medication issues. So there's a 2012 study that looked at the most common predictors of low medication adherence. So out of any patients in this study, the patients that were most likely to have a low level of adherence were African American women that were treated in a publicly funded primary care facility, which would include an FQHC. And also in the study they've mentioned that the treatment in a publicly funded clinic was a marker for a lower level of socioeconomic status. And as we saw earlier, older women, and especially older African American women, tend to have really high rates of hypertension. And so these are patients that are not adhering to their medications and also need treatment and need the follow-up. So from your perspective and what you can do to help us ensure that patients are following a prescribed medical regimen, make sure to ask if patients are able to obtain their medications easily. A lot of patients have transportation issues or aren't able to set up mail order medication, and so it's important that when talking with patients, you check and make sure that they're actually able to get their medications, and also that they have an understanding of when and how to take their medications. So some patients don't realize that medications for hypertension need to be taken on a regular basis, not just when they feel sick or feel like they need to take their medications. There's actually a regimen that they need to follow. And to help with that, you can encourage patients to use medication reminders. So whether that's an alarm on their cell phone or a pill box or putting their medications next to a daily routine such as brushing their teeth, using those little hints and reminders can help patients follow their medication regimens a little bit more closely. And also check in and making sure that to see if patients are experiencing side effects from the medication. If patients aren't encouraged to talk about potential side effects, they're more likely to actually stop taking the medications altogether. And check at every appointment to make sure that patients have an understanding of this medication's importance and that they know why they're taking their medication, and have the patients actually tell you, why the medication that they're taking is important, which will show give the patients education on why the medication is important, and also give them some self-independence with their medication regimen. Okay, and looking at lifestyle for addressing the disparity, this is something that is very difficult to, and when you're limited on time in clinic, it's very difficult to attack these issues. But it's important that they're discussed and that patients feel like they're able to discuss these. So encourage lifestyle modifications in your hypertensive patients. You can tell them that weight reduction is actually the most beneficial thing that they can do to treat their hypertension. For every 22 pounds that patients lose, their systolic blood pressure can drop anywhere from 5 to 20 points. Also, by changing their diet, there's a diet that is very common and popular now to recommend to patients with hypertension, which is the DASH diet. The premise of the DASH diet is that it's low in salt, total fat, saturated fat, and cholesterol, and higher in fresh fruits and vegetables for patients. And it especially includes foods that are high in potassium. And although it's difficult to have patients change their diet completely and their eating habits entirely, it's very important that we encourage patients to consider making small changes in their diet and maybe using some of these principles from the DASH diet into their daily routine, so that way it's not throwing off their entire cooking regimen and shopping regimen, but encouraging them to take slow steps to improve their diet. And so physical activity is also an important lifestyle change to promote. It's recommended that patients with hypertension exercise at least half an hour for 5 times or more a week, which can be difficult for a lot of people in their busy lives and routines. But just advising little things like parking at the far end of the parking lot to walk into the grocery store or work, taking the stairs instead of the elevator, and just encouraging people to be active and to look at ways of incorporating physical activity into their life. So smoking and not smoking. Smoking, obviously, as we discussed, increases your risk of hypertension and also reduces life expectancy. And these numbers are from a 2004 study. In men who smoke for more than 20 years, they have a 13-year lower life expectancy than men who don't smoke. In women, it's even higher at 14.5 years. So for patients, especially patients with hypertension, encouraging them to stop smoking is an important lifestyle modification. And consuming alcohol in moderation, we discussed this before, but 2 or fewer drinks per day for men or 1 or fewer drinks per day for women can be an important lifestyle modification to lower hypertension. And this chart kind of just summarizes everything that we just talked about and shows the weight that each modification can have in reducing hypertension. So weight reduction is obviously the highest, dietary changes, physical activity, and alcohol consumption being important as well. Okay. And something that will help patients in their hypertension is improving their understanding of the hypertension. So limiting the amount of information that's provided at each visit so patients can access this information readily. Delivering information at a slow and accessible pace for patients, avoiding complicated medical terms, using pictures, models, or other visual aids to explain important points, discussing the risks and complications for uncontrolled hypertension, such as heart attacks, cardiovascular disease, strokes, and assuring that patients understand the information. So having patients actually teach back or tell you what they've learned at their visit and what they're going to do differently or work on changing before they come back another time. And also encouraging patients to ask questions. And most patients at the end of a visit will have questions, but often they feel rushed or they feel like they've been waiting a long time or don't want to bother anybody with questions. So by just changing the way that you phrase, do you have any questions, and changing that to what questions do you have, with the assumption that the patient has questions, just which are they, and just the way that you can ask and elicit questions can make a significant difference as well. Okay. All right, so to touch on really quickly different resources that you can use for patients. If your clinic doesn't have any kind of information or flyers for patients with hypertension, I highly encourage you to look at these different websites, and they provide a number of great resources to use. So the American Heart Association has high blood pressure resources. The Center for Disease Control has an excellent educational page for patients. The Million Heart Initiatives, which is a collaboration between a bunch of different organizations that was started in 2011, actually has a ton of information for both healthcare providers and patients, and it's a wonderful website. And the National Institute of Health has resources for the public, and actually has different resources for different ethnicity and race groups. So I know specifically they have hypertension information for Hispanic populations. So if you have people in your clinic who are primary Spanish speakers, the National Institute of Health resource would be a good one to look at. And also some more information on the DASH diet through the Mayo Clinic has a good summary website. And smoking cessation tips, patients can look at smokefree.gov or call the 1-800 number Quit Now and receive more information on smoking cessation groups and how to curb their smoking habits. And different data resources that we used in this presentation for those that are interested or want to look at them later. Looking at the FQHC specific data through the Uniform Data System. It's publicly accessible. You can use that website. The County Health and Rankings and Roadmaps website that we looked at for health factors specific to Louisiana. You can look at the second website there. The third website has different information for how Louisiana ranks compared to other states, and that's where we learned that Louisiana was the fourth highest rate of hypertension in the country. The CDC has a bunch of different websites to look at hypertension rates specific to location, and then also the Behavior Risk Factor Surveillance System, or the BRFSS, has some good data resources as well for anyone who's curious. And this is a brief list of citations that we used in this presentation. If anyone would like a longer list of citations, I'm sure that Ms. Shannon and I can I'd happily provide that for you, or you can feel free to email us directly for that. So, in conclusion, hypertension is a commonly encountered health problem in Louisiana, and especially our FQHCs. Different populations are more vulnerable to hypertension based on race, gender, and a variety of other factors. And patients often face social determinants of health that create difficulties in controlling their blood pressure. And it's important to recognize that you can make a difference in your patient's blood pressure control, and that there are steps that you can take to help your patients with their health outcomes. So with that, I'd like to open it up for questions and ask, what questions do you have at the end of this presentation? And I believe Ms. Shannon is tracking that for us.
Yes, thank you, Alex. As a reminder, if you have a question, please type it in the question box located on the webinar screen. Our first question is, how do I relay the patient information I discover to the rest of the healthcare team?
Sure. So a lot of times, yeah, patients may discuss in passing what they're doing to change their blood pressure. They might mention that they're not adhering to their medication, or that they stopped taking their medication because they're experiencing some side effects. And that is very important information that you'd want to relay on to the healthcare provider, or the nurses, the doctors, the NPs that are taking care of this patient. You want to make sure that that gets communicated throughout the team, and that that information ends up in the patient's electronic health records for the future. So making sure to communicate that information appropriately throughout the team is very vital.
Okay. Our next question is, it's often difficult to lose weight. What do I tell patients who are frustrated about the difficulties of losing weight?
That's an excellent question. And as we saw in the presentation, weight loss is the most beneficial thing that patients can do for controlling their blood pressure without medications. However, it's also one of the most difficult things for people to do. And it often can be a source of discouragement, and people feel frustrated with it. But it's important to tell patients that studies have even shown that by increasing their amount of aerobic exercise, and exercise when they have an increased heart rate, eating a diet that's low in sodium and low in salt, and sticking to a medication regimen will actually help reduce blood pressure regardless of whether or not they're losing weight. So if you have a patient who's trying really hard but not losing weight, encourage them to focus on their diet, focus on their exercise level, and focus on sticking to their medication regimen, and they'll have good blood pressure control just through that.
Okay. Next question. For some patients, it's hard to understand the significance of controlling their blood pressure. They don't feel bad or sick on a day-to-day basis. How do you stress the importance of controlling a patient's blood pressure?
Good. Okay. It's an excellent question, and something that's commonly encountered because patients with hypertension often don't feel sick or don't feel bad, and so it's difficult to encourage them to treat it. So it's important when you're discussing hypertension with patients that you emphasize the risk that hypertension introduces to their health care. So hypertension, as we discussed, leads to kidney damage, end organ kidney damage, eye issues, heart attacks, strokes. So patients with hypertension have a much higher risk of disability due to one of these other significant illnesses, and also a decrease in their function. And so it's important to emphasize that without controlling hypertension, you have a much higher risk of these other significant illnesses: heart attacks, stroke, kidney disease, which can decrease their functionality and quality of life. So asking patients if they know somebody who's had a heart attack, or they know somebody who's had a stroke, and if they know somebody who has kidney damage and is on dialysis, and emphasizing that, that's something that you want to avoid the patient getting to. You want to avoid getting to that level of dialysis or a heart attack or a stroke. And by controlling your blood pressure, you can help minimize the risk of having those very serious health outcomes.
Okay. It looks like that's all the questions we have for today. I would like to take a moment just to thank you again, Alex, for conducting this presentation today. This concludes our Learning Series webinar. As a reminder, our registered participants will receive an email follow-up for Part 3, which will be the final webinar of this series once the date is confirmed. Thank you again for participating in this Lunch and Learn session. Have a great day.
All right. Thank you, everyone. And please feel free to email us if you have questions about any of the resources or you'd like some citations. Okay. Have a good day.